The colorectal cancer, landscape has become a little bit more complex, and there's been quite a bit in developing agents in patients beyond second and third line. Many of these are actually targeted agents, where we pick a lot of them on liquid biopsies, but tissue remains the gold standard. And when we look at the subgroups, I mean, we have the HER2 amplified, we have the BRAF V600E, we have the KRAS G12C, MSI high, and others as well. So there's been quite a bit going on in the HER2 space in patients with metastatic colorectal cancer. There has been 3 studies that essentially paved the way. First, 2 main ones, Heracles A and My Pathway, which essentially led to the whole interest in this field. And then in the red box down there are 2 studies that I think are now driving our standard of care. Tucatinib trastuzumab, which was just approved by the FDA on January 19th, based on the Mountaineer study that ran through our research consortium in its first cohort, and then went back to the company. And then trastuzumab deruxtecan, which appears right now at least to have mostly a role following other HER2 target therapy, so following tucatinib trastuzumab in that sense. The other target of interest is KRAS G12C. That's in about 2% of patients with colorectal cancer. This paper was published in New England Journal of Medicine just recently, looking at adagrasib plus cetuximab versus adagrasib, which is a G12C inhibitor. Now, similar to the BRAF V600E story here, is once you're targeting the KRAS, the MAPK pathway, whether it's RAS, BRAF, or anything downstream, there's this feedback loop mechanism that activates EGFR inhibitors, and then it makes it key to target the EGFR inhibitor along with the G12C inhibitor to be able to get the responses. And it's obvious that when you look at adagrasib versus adagrasib plus cetuximab, and I say versus, these were not compared in randomized fashion, but in parallel ways, the response rate is definitely better with the 2 versus the 1. That's true also for sotorasib plus panitumumab versus sotorasib. And with V600E mutations, we have the Beacon regimen that's also approved in this instance for patients with refractory disease. The doublet with a RAF inhibitor plus EGFR inhibitor, so encorafenib plus cetuximab, was approved over the triplet because of very similar outcomes and more toxicities with the addition of binimetinib, and that's another standard there. The other study of interest is Keynote 177, that's in first line, not as much in the refractory setting, that really moved pembrolizumab to first line based on improvements in progression-free survival and ultimately overall survival, although non-statistically significant for OS, but clinically meaningful in that sense. And it's when you look at patients with a targeted strategy, it becomes clear that as we start honing in more and more on these targets and come after them with targeted agents or immune therapies, that both the progression-free survival rate as well as the objective response rate continue to improve gradually but surely. So as we get more of those targets, unfortunately, though, this amounts to only 15 to 20% of all patients with colon cancer. About 80% of the patients with colon cancer do not have a target. So after first or second line therapy, then we start thinking about what next. And there are 2 agents at least, and a third on the way that are part of the refractory armamentarium. One of them is regorafenib. Regorafenib is a multikinase inhibitor, initially approved at 160 milligrams per day, which ended up being quite tough on patients and certainly led to a lot of reluctance to use it. And there were a lot of different ways to use this agent in clinic, but nothing that was assessed, in a randomized fashion. So we took on this study, the REDOS study, which aimed at dose optimizing the dose, the dose of regorafenib by essentially looking at the dose escalation strategy, starting at 80, 120, and then 160 on a weekly basis, escalate that versus standard dosing, which I'd say, today is not so standard anymore at 160. And the primary endpoint of the study essentially was, 1% of patients can we get through 2 cycles and then start the 3rd cycle. And in that sense, you're looking at a composite endpoint that integrates safety. The agent has to be safe enough for patients, to move on into the 3rd cycle, and it also had to, allow for disease control to move on to the 3rd cycle. And the study was positive for its primary endpoint. Close to half of the patients who received regorafenib at a dose optimized strategy were able to reach cycle 3 and beyond, versus only 24% on the standard dose. So in that sense, the primary endpoint was positive. And, we looked at the primary endpoint. The primary endpoint in the study was positive. We looked at the secondary endpoint of overall survival, which did also show an improvement with the dose escalation strategy at 10 months versus 6 months. It was not statistically significant, but this was a secondary endpoint, and the study was not powered for that. But it was interesting to see that that's better. And it kind of makes sense. I mean, if you reach the primary endpoint, which gets more patients going to cycle 3, that could translate into improvement in outcomes. When we look at patient by patient data, it becomes clear that about 40% of the patients were actually able to get to cycle 3 and move beyond cycle 3. For about 30% of the patients, 80 milligram was the right dose. So that's important to keep in mind, because the study was actually looking at a dosing strategy, going from low to high, so escalating versus de-escalating. And each subgroup of patients ended up with, an optimal dose to move forward with from 80 to 160. Also, the quality of life of patients was maintained with the dose escalation strategy. For those of you who use this and have used the 160 milligrams before, you certainly could tell a significant difference between, how we manage patients on regorafenib at 160 and how improved all this has become once we move to the dose escalation strategy. We've also done a couple of those. This was one of the more recent network meta-analyses looking at all the randomized studies with both regorafenib and TAS-102. And the gist of this is, and that's the blue curve here for survival, that regorafenib at 80 milligrams going onto 120, 160, historically outperformed, at least in this network meta-analysis, Rego 160 and TAS-102, and all of them did better than essentially best supportive care and placebo. And same, with the PFS, there's certainly a hint that with regorafenib at 80 plus, you actually get a little bit better outcome versus the other strategies. At ASCO GI 2023, there was a study that was presented. It's called the Sunlight Study, looking at TAS-102 plus bevacizumab, plus minus bevacizumab in the 3rd line. So it's important to emphasize that this was a 3rd line study. So it's a little bit earlier in the game than the other studies. And it did require patients to be exposed to prior chemotherapy. Now, the overall survival from the study was positive for its primary endpoint of overall survival. So bevacizumab with TAS-102 was better than TAS-102 alone. And that appears to confirm the results of the phase 2 study. But that does come with a caveat. When you look at the prior bevacizumab exposure, it wasn't actually 100% as we hoped. It was essentially 72% and 28%. 28% of the patients did not receive prior bevacizumab. And that actually comes mostly from the rest of the world and some parts of Europe, where there's less access. You can see that the US contribution to the study was pretty small. It was about 16 patients total. But overall, the patients who essentially were included in this study, when they had prior bevacizumab, their survival was actually lower than the median for the overall group, 9 versus 7.1 months. So the difference became actually less pronounced. Whereby those that actually did not have prior bevacizumab, the difference between TAS-102 and TAS-102 bevacizumab in terms of survival was almost double with the addition of bevacizumab. So that certainly, affects the analysis. Now, this is the PFS rate, which was also superior with the addition of bevacizumab. And when you look at the overall toxicities, it is obvious that there are a few more toxicities with the TAS-102 plus Bev, but that's not unexpected given the fact that more patients, are exposed to TAS-102 beyond cycle 2. Unlike Regorafenib, where most of the toxicities tend to happen in the first 2 to 3 weeks of treatment and at their worst, so early. With TAS-102, other than the hematologic toxicities, most of the other toxicities like GI toxicities, fatigue, nausea, etc., those tend to happen after 2 cycles of treatment. And that's why you see a little bit more in the TAS-102 plus bevacizumab. But I think what this study tells us essentially is that for a patient where you choose TAS-102, you have to add bevacizumab. So for a patient that you choose TAS-102, you have to use bevacizumab. As I said, again, in the US, it'd be almost impossible to find a patient who hasn't had prior exposure to bevacizumab to see the same effect that they've seen in other parts of the world. There's another agent called Fruquintinib, which is primarily it's a VEGF inhibitor, VEGF receptor inhibitor, but it has also other off-target effects. FRESCO-2 was presented at ESMO and essentially shows that patients who received Fruquintinib had a superior PFS and a superior overall survival versus placebo. Now, this study was interesting because not only that it went through multiple lines of therapy, but allowed prior TAS-102 and Regorafenib. In fact, about 40% of the patients had both prior TAS-102 and Rego. And about 60% of the patients had either TAS alone or Regorafenib, and then 40 both. So a lot of patients received essentially the two agents before going on Fruquintinib. And when we look at the toxicities with Fruquintinib, then mostly hypertension and asthenia, which is quite expected with this tyrosine kinase inhibitor. You do see about 20% of the patients having hand and foot syndrome, and about close to 6% of those patients will have severe hand and foot syndrome reaction. And when you look at the subgroup analyses for patients with OS and PFS, it is clear also that those patients who had exposure to both TAS-102 and Regorafenib continued to benefit from Fruquintinib. So that's nice to know because now, now we have yet another layer following Regorafenib and TAS-102 and bevacizumab, and you have Fruquintinib now coming to that space to add options to our patients. Now, when we look at, and of course, these are, indirect comparisons of modern studies with Rego, Fruquintinib, and then TAS-102 plus Bev. So with Regorafenib, since most of the usage is according to REDOS, it's important also to look at, REDOS required all patients to have pre-exposure to bevacizumab, and then those eligible to EGFR monoclonal antibodies. Not 100% of the patients, but 100% of the eligible patients. And when you look at prior lines, these were more refractory patients, more than 3 lines of therapy, so 4+. No one got it earlier. and you see the median survival. For fruquintinib, again, very similar. I would say that in this case, patients also received regorafenib and TAS-102 at high rates, and these were more refractory patients, and you can see the survival below. When you look at SUNLIGHT with the TAS-102 plus minus bevacizumab, and on the orange side, if it's patients with no prior Bev, which frankly is not as applicable to our patient population. But when we look at the prior Bev, you can see that those patients had less or equal than 2 prior lines of therapy. And again, you can see the survival deltas down there. One of the elements also with SUNLIGHT that's a bit concerning to me is they haven't really reported out on percent of patients who have had prior EGFR inhibitors. So we don't know how many patients were exposed to prior EGFR inhibitors, and certainly that can affect the tail end on survival following TAS-102. The other element also is very few U.S. patients, which certainly limits interpretation. But these are the results. So what do we do today with colon cancer in 2023? So if you have a left-sided tumor with a RAS wild type, BRAF wild type, HER2 amplified tumor, these patients would go on chemo plus anti-EGFR, but also you can argue these can go to triplet FOLFOXIRI plus beva. For those patients who have a BRAF V600E mutation, encorafenib and cetuximab or panitumumab would be their standard, preferably in the second line. I wouldn't wait to the third line. And then HER2 amplified tumors, I would go with tucatinib, trastuzumab first, and then trastuzumab deruxtecan next. For those patients, would exclude EGFR inhibitors given the data, including some of the data we presented at ESMO in Paris, that would lead us to exclude EGFR inhibitors. I didn't talk much about TMB high, more than 10. I mean, in colorectal cancer, I think you really have to go above 20 plus to have any benefit from single agent PD-1. Then for the refractory, those are about 80% of patients who go beyond first or second line. Then regorafenib using the dose optimization strategy, TAS-102 and Bev, and then fruquintinib. And then, of course, the G12C inhibitors are starting to make their entry points. So thank you, and we'll move to the cases. First case, Dr. Kotla. Charles, is Dr. Kotla? Okay.
Yes, that was a good presentation.
Thank you.
So this one was a little bit of management dilemma. I did not start this patient on therapy, but was a patient of my colleague. So stage 3A and adjuvant, treatment decisions, and I think the dilemma initially was 3 months versus 6 months because of the IDEA trial. But there was a Signatera test drawn at some point in the beginning, so it was positive. So the patient transferred around 3 months of therapy, and then she saw me and was having a lot of neuropathy issues. And so the question patient had was, if ctDNA was positive at the time of adjuvant decision, does the IDEA trial still, the results apply? And should we be giving these patients 6 months instead of 3 months? So I could not find a good answer for that. And so I wanted to see what your thoughts are.
Well, that's because there is no good answer, that's available to us. However, you would think that a patient who essentially was positive will have a risk of recurrence of about 100%. That's before chemotherapy. The question is, does it apply after chemotherapy? And this is where we're starting to see some of this emerging data that suggests essentially that for some of these patients, adjuvant chemotherapy may delay progression, and it could essentially enhance the risk of a cure. But we don't know that pending long-term follow-up or randomized studies. From my standpoint, this is a patient where I would consider giving 3 more months of 5-FU or capecitabine. I guess the oxaliplatin is not an option, but frankly, the primary the primary benefit will come from the fluoropyrimidine, not from the oxaliplatin. The oxaliplatin adds that much more to the toxicity than to the benefit. So there was, data from France, from the idea of France, not from the whole study, because, the collection of ctDNA was not, was not across all the studies, trials that entered into the idea. But from Trial France, I think they published this in one of the Nature journals, that essentially did show that those patients may benefit from chemotherapy. So I would from additional chemotherapy from the 6 month. So I would consider 3 more months of either 5-FU or capecitabine. I wouldn't worry about the oxaliplatin at this point.
Perfect. All right. Thank you for your answer.
Yeah. No, thank you. Great case. Thank you. We're going to see more and more of these cases that do challenge us, right? And that's good as we continue to learn more and more, about the value of these tests into the clinic. So thank you for this case. All right, Dr. Moraveni.
Yes, sir. Thank you for a great review.
Thank you.
Always learn something. So this lady, interesting one, who saw not too long ago, 53-year-old African American, no past history at all, not on any medication, with a 2-week history of abdominal pain and significant weight loss. Scan showing, unfortunately, multiple liver lesions, largest 73 and 36 as measured, near obstructing ascending colon mass, and she's severely symptomatic. All the liver biopsy was confirming adeno. She chose to have a hemicolectomy as she was symptomatic and obstructing. So IHC all consistent with the colon primary, and grade 3. She did have a KRAS exon 4 mutation positive. Everything else was negative. BRAF, NRAS, HER2, MSI is low, MMR is intact. So, she is more of a believer of alternative therapies, but I had a long discussion about systemic therapy. I just want to see your take here in this, young female.
Good performance status?
Yes, very good performance status.
Yeah, so young, relatively young. I mean, 53 is relatively young, I would think, right? And younger and younger with as we age. So this is metastatic disease, obviously. The patient, is presenting with synchronous metastatic disease. Are those the only 2 lesions in the liver?
That is correct. Only 2 lesions.
Okay.
Yes.
Okay. One is pretty large, though, 7 centimeter. This is a patient I would actually want to be as aggressive as possible. I think I would go with FOLFOXIRI plus Bev. I would give 2 to 3 months of FOLFOXIRI plus Bev, and then reassess. So I would reassess and look at the liver lesions and see where they at. Then consider local regional therapy for the liver. And then following that, may consider CAPE plus Bev or just giving the patient a break. This is a patient actually where I would, after FOLFOXIRI Bev, if I take her to surgery or do local regional therapy, give it about 4 weeks. This is a patient I may actually consider MRD assessment.
Sure.
And follow her if you decide on no treatment. If you decide on treatment, it's a little bit trickier. If you decide on no treatment adjuvantly, which I tend to favor, I tend to like to give patients breaks, then you can check MRD and just follow the patients between MRD and scans. So FOLFOXIRI Bev, 2 to 3 months, CT scan, consider local regional therapy. I mean, she will have more than 70% chance of responding to treatment. And then consider plus minus adjuvant therapy. Oh, it wouldn't be adjuvant. It would be more like a maintenance therapy.
Right.
And then consider, if no therapy, MRD assessment. Does that help?
Yeah, sure. Thank you.
Okay, great. Thank you. All right, Dr. Walden.
Hello. So this is a case, 6-year-old woman, stage 4 CRC, originating from the transverse colon, with synchronous unresectable bilobar hepatic mets. No other metastatic sites. We did NGS, microsatellite stable. She did have a KRAS G12V mutation. She got upfront FOLFOX Bev. She had a PR with that and was placed on maintenance capecitabine there afterwards. She had a hepatic progression after 6 months of maintenance, cape, no other extrahepatic disease. We put her back on FOLFIRI, and then we also referred her to our IR colleagues, and she got transarterial radioembolization with Y90 with concurrent Bev. She had really good radiographic response, and it lasted for about 8 months prior to disease progression in the liver and omentum, as well as some new lung nodules. She remained quite active, good performance status. We did proceed with Regorafenib per the dosing regimen we discussed previously. Her max dose was 120, and she tolerated that quite well for about 8 weeks, but did have some disease progression. I'm sorry, for 9 months until she began to note some disease progression. And question kind of is now, given the quantity of VEGF inhibition in the context of the Sunlight trial and other novel VEGF inhibitors, kind of your thoughts on what we'd want to do, here from this point.
Yeah, no, it's interesting. I see that, when you did her scan, she had some cavitation in her lung lesions, and that's that would be consistent with what you typically see with Regorafenib. It is a surrogate for a response, which doesn't surprise me that her CA would be improved. So when you tried to go with the redose, you said her maximal tolerated dose was 120. So I'm assuming that when you tried to go to 160, she had some toxicity. What was it? Hand-foot syndrome reaction, fatigue?
Hand-foot, yeah.
Hand-foot.
Mainly the mouth. She did a lot of stomatitis. She couldn't really.
But not when you went back to 120. It was clear.
Tolerable, yeah.
Okay. So good response, really good response with Regorafenib. Patients had FOLFOX Bev, then FOLFIRI Bev, and Y90 in the middle. And now Rego, she has a KRAS mutation, no other druggable targets. So I think the logical progression of events, as I would do in my clinic as well, is this patient would go. Previously, we would go to TAS 102, but now I would do TAS 102 plus Beva, given what we've seen with Sunlight. And like I said, since there's prior VEGF inhibitors here, probably the benefit from TAS 102 and bevacizumab is probably a little bit less pronounced in the presence of pre-exposure to VEGF inhibitors, but it makes the most sense to do TAS 102 plus bevacizumab. Did she have any significant neutropenia, pancytopenia with FOLFOX or FOLFIRI?
Towards the end of FOLFIRI, she started to get some progressive neutropenia. She required a dose or two of Neupogen, and that was kind of our signal that she was probably at her limit for systemic chemo. Got
it. Yeah, I'm not sure that that's a surrogate, an indicator that she will experience issues with blood counts with TAS 102 plus Bev, but that's something I would probably keep an eye on as you move her to TAS 102 plus Bev.
Awesome. Yeah, agree. Thank you.
All right. I think that's our last case. Charles, anything else? Any questions?
Dr. Saab, yes, one quick question. Rob Zayden here.
Yeah. How are you?
Doing fine, thank you. Excellent presentation. I'll echo everybody else's comment on that. One practical question: in the setting of a patient that has no mutations, has progressed through all 4 lines of therapy, and is not a candidate for a clinical trial, do you go back and re-challenge with FOLFOX or FOLFIRI, especially if they've had neuropathy from a lot of the other treatments? I'm just
So
curious what
assuming
your
that-
personal pattern.
Okay, assuming the neuropathy has resolved.
Yeah,
Neuropathy
this is a
resolved.
grade 1 to a grade 1.
Okay. So, and this is a patient who had prior exposure to an EGFR inhibitor as well.
Yes, either that or we're not a candidate for it because of lack
Okay.
of mutation.
Okay. So let me split this 2 ways. One, let's say this was RAS wild type, HER2 non-amplified BRAF wild type, had prior EGFR inhibitor, had somewhat of a response to an EGFR inhibitor, then progressed. I would check, circulating tumor DNA after Rego and TAS-102 Bev. And if you can see that those, wild type clones are persistent and there are no indicators of mutated clones, those patients can be re-challenged with an EGFR inhibitor plus minus chemo. And you get about 30% chance of seeing a response again. It could be short-lived. It's not an impressive response, but you could see a response back. For those, let's say, with a mutation, and assuming it's a non-G12C mutation in RAS, those are the patients I would reconsider re-challenging with chemo. The question is, how do you do it? As you said, I wouldn't put it ahead of Regorafenib or TAS-102 Bev at this point. I would put it after. I've re-challenged patients with FOLFOX. I've re-challenged patients with FOLFIRI, as long as they've had an indication of a response, early in the line of therapy, because I wouldn't re-challenge them with something that hasn't given them response. Occasionally, in the younger patient that hasn't received FOLFOXIRI in the first line, or even some that may have had a really nice response, and they still have enough performance. And, our younger patients are getting to, 5th line of therapy with great performance status, no toxicities. I've actually gone to FOLFOXIRI, and I've seen some interesting outcomes for some of the patients. Again, those are, in the absence of, any rational targets and any clinical trials. That's what I've done for those patients. So I think it's reasonable, short of any other options. Fruquintinib may be approved. We'll see. I think the application is at the FDA. So Fruquintinib may be approved, and it may add 1 layer for you.
Wonderful, thank you.
Okay. Thank you. Great question.
I have a question.
Yes,
For patients with stage 2 colon cancer, they do not have any risk factor. Can you make a case of using Signatera or circulating tumor cells to justify adjuvant chemo or not?
So low risk by traditional standards, low risk. Those are the patients that were included in the dynamic study. Personally, unless the patient wants to consider chemo, so after a discussion with the patient, because those patients with a very low risk feature, I don't tend to treat, as most of us don't tend to treat automatically. But, if the patient is questioning the no treatment option, the watch and wait, and many times now we see those patients coming and asking for these tests. Those are the patients I may do a test. And if I do, I will also, it will elicit a long discussion about the false negatives and those false positives and what it means, and taking the caveats. If that patient ends up being positive, I am compelled to treat. Those are the patients, if we look at now the longitudinal data from these, prospective observational studies, it does suggest that there may be, an element of benefit from exposing them to chemotherapy, maybe on the short term. We don't know the long term yet. So I wouldn't do it automatically for the low risk patients. But more and more, you're going to see either a patient, asking for it, or, perhaps with the younger patients, where there's a discussion about a possible chemotherapy, even for a very small benefit, that's where, enters MRD assessment in that group of patients.
Okay, great. Thank you.
You're welcome. All right.
And wrap it up here. Thank you, everyone, for taking some time out of your evening. I appreciate the cases and the conversation. And Tony, nice talk. Until next
Thank you.
time, everybody have a nice night.
All right. Thank you. Have a good night.
you.
Bye-bye.
Thank you.
Thank you.
Thanks, everyone.
Thank you.
Thank you.
Thanks.